Hello and welcome to IndiGlobal Cancer Care Symposium, the art of conquering cancer. We are in the first panel discussion of this very important symposium that would continue for tomorrow as well. We had a very useful and important, amazing inaugural session today with participation from policymakers, healthcare leaders, and also those who are from the government of India. We saw participation from the Ministry of Development of Northeastern Region, Government of India, the Northeastern Council, and also from Jammu and Kashmir, from the state of Kerala, Telangana, putting forward various perspective on how the cancer care can be accessible and affordable besides public private policy and public intervention. Now we are in a very important panel discussion that would be focusing on early detection, accurate intervention, and monitoring of cancer. This particular symposium has been designed in order to bring in the much needed attention and awareness and build that kind of and enhance the education towards the cancer as a disease and the possible and accurate education and awareness towards this disease that is the second largest cause for deaths across the world. In India, by 2020, there were like 1.39 million cases registered according to the National Cancer Registry Program, and it is likely to go up by 1.57 million by 2025. There are medical technology advancements and infrastructure, healthcare infrastructure development, which is resulting in prolonged life expectancy, and also many were cured of cancer. However, the cancer is on rise, so which demands for review, constant review on our approach towards cancer care and also treatment. So this particular session would delve on the early detection, therapy selection, and pre and post cancer treatments and monitoring. So we have some seasoned experts who have joined us from across the country. Please join me in welcoming our first speaker who has joined us all the way from the waterfall state of a country, Jharkhand. She is Dr. Pallavi Pandey, Executive Director, RJSP Cancer Hospital, who comes with decades of experience being a gynecologist and also the Executive Director for RJSP Cancer Hospital in Ranchi, Jharkhand. Welcome, Dr. Pallavi. Thanks for joining us.
Thank you, Sudheer. Thank you so much.
We are also joined by a pioneer in research and development. She is a seasoned expert in cell biology. She has worked in Singapore and several other countries in the field of R&D. Now she is back to India, serving India. She has founded this very important organization, OncoStem Diagnostics. She is the chairman and founder and CEO for OncoStem Diagnostics. Please join me in welcoming Dr. Manjiri Bakre, joining us all the way from Bangalore, Karnataka. Thank you very much for joining us,
Thank
Dr.
you,
Manjiri.
Sudheer, and great to be here on this forum. Thanks for having me.
Thank you. We are also joined by yet another young, passionate, seasoned healthcare professional who is known for his passion for various transforming healthcare scenario and operations in the hospital sector. Please join me in welcoming Mr. Saurabh Gupta, who's the regional COO for KIMS Hospital. Welcome, Mr. Saurabh. Thanks for joining. We are also joined by Mr. Varun Sharma, who is the Assistant Vice President for Growth and Business Strategy with American Oncology Institute, which is also Center Cancer Treatment Services International. Please put your hand together for the seasoned professional Varun Sharma. Welcome, Varun. Thanks for joining.
Thanks, Sudheer.
With
Thank
this
you.
first, I would move on to our first speaker, Dr. Pallavi. I would like to come to you. You are the executive director. There seems to be a technical, yeah. Yeah. So first, I would come to Varun. Varun, you have this amazing experience in regards to regarding to cancer, and the role of technology is very important. And you have been working in it, in and out. Uh, what would be your perspective that how early detection uh, accurate intervention can happen, and at the same time this monitoring of cancer can be done before and after the cancer is detected, because there are good chances, and there is uh, relapsing the cancer again prevailing once again even after surgery, and proper treatment is a challenge always. Your take on it?
Yeah, let me first thank you, Sudheer, for organizing this, conference because it is very important while we are in a cancer and we are talking about cancer, which is a pretty serious disease and is the leading cause of not only the deaths worldwide, but also for a country like ours, right? When we look at it, and it has got a lot of economic devastation apart from it, being a traumatic disease for the entire family. And when cancer strikes someone in the family, it is actually the entire family that suffers. So, I thank everyone and I thank you especially for organizing this. That's the first thing. Second thing, your question is pretty loaded because detection itself and early detection itself is a huge challenge for a country of our size, right? And then a country has a lot of other factors which actually prevent early detection. It's quite unfortunate that despite having a lot of technology now and despite having you know quite a good manpower which is pretty talented and recognized across the world, we are still, roughly around three-fourths of our cancers are detected in a pretty advanced stage. And the reason for that, there are multiple reasons, and that it's not that India is unique in this. It's entire Southeast Asia or developing countries basically suffer for that. And there are many factors actually, uh, or the challenges that we have, which make it a little difficult for us to detect it early. While early detection or a prevention will have a huge impact and economic impact and impact on, saving lives, because there are a lot of cancers now which are preventable cancers, and there are a lot of cancers which are curable cancers if they are detected very early. So, it will not only have an impact on psychological impact on society or economic impact, right? We can save a lot of money also on that because the treatment becomes pretty economical when it is detected early. So let me address that. First, the challenges, because the solution is going to come from the challenges only when we are going to address those challenges. See, the biggest challenge is in this is the infrastructure challenge, because we know that it is largely true for other diseases as well, but more so or more pronounced for cancer, because the infrastructure available for detecting cancer at a district level, at a taluka level, because Indian healthcare suffers from a distribution issue. So if you look at healthcare infrastructure availability is largely urban driven, where you have 35% of the population and you have rural population, which is 60 or 65% of the population, which is still, have to travel to some distance to either go to a district level or go to a tertiary care centers for detection. So that is a first level of challenge, the distribution of healthcare facilities or healthcare actors or doctors, etc. So that makes it difficult. Second thing is the education, because the only thing that can actually encourage and motivate people actually to get themselves screened faster or screened early whenever they feel that there are symptoms, etc., and all those things, that's our biggest challenge, because there's a lot of trauma, there's a lot of fear that's been created over a period of time, in cancer, that's not treatable. It's, so it'll have, so once you have detected with the cancer, it's a death sentence, etc., and all those things. Those kind of so attitude towards cancer is actually a stumbling block. So there's a lot of education which is required. And when you say that education is required to drive the attitude towards health, basically. Because if you create those attitudes in a larger communities and a societies, right, through various programs. So before I come to the programs, I must say that the design of that program, so for communities. So that is one part which will also help remove the taboos. So if you travel, since I've been working in cancer for almost now 6 or 7 years specifically, so if you travel to the hinterlands of the country or to the district level or even in urban areas, you will find a lot of attitudes towards cancer is completely different. And there are social practices which are there, which are also, against this. And you see the largely, if you see 38% or 36% of the cancer happens to be women cancer, right? And then you have the second large, or the largest cancer is head and neck. So these are 60% of the cancer. And then you have practices which are completely preventable, right? So you have a tobacco. So you're gonna right now our focus is basically on de-addiction of tobacco, but rather than preventing the first somebody who is starting tobacco use and all those things. So there are a lot of work which needs to be done in education only, that how you're going to educate, what exactly you are going to educate about, right? Are you going to educate about only the signs and symptoms, right? Or you're going to educate about the larger health attitudes towards it? How do you make it a part of, because you have schools available everywhere or you have colleges available everywhere. So how do you make it a part of education, right? The moment it becomes a part of education, and then you drive attitudes towards that, and then a lot of things can be done in it. You got a PPP, you can have initiatives around that. So that actually, you work on that, then you work on communities. You have some amount of infrastructure or manpower available in form of ASHA workers, in form of NGOs, in form of a lot of other actors who continue to work on health. So those are health activists, etc. You can drive education through them also about this early detection. So that is where you work on detection. Then there is a technology which is available which can also drive education and awareness about it, because through education you can create an awareness, and then you can create awareness about lifestyle, about other factors which lead to cancer. A lot of cancer is related to lifestyle, a lot of cancer is related to the other environmental factors. So and then a lot of in lifestyle you have these things. So you use the technology because that reduces your cost, right? And that makes it possible for everyone to reach. Everybody is available now on social media. India happens to be the largest country in the world, where you have a 40 crore people in social media of all kinds of platform put together. So you drive these things. And another biggest challenge actually which comes to detection is that there are a lot of people who are working in cancer space, they're all disjointed, right? There's no platform. So you have a platform like National Cancer Grid now, where you've got a 238 hospitals coming together and driving protocols, and trying to reduce the cost of the pharmacies, etc., and all which is required. But the similar efforts can also be created while you are creating awareness education for screening, right? And then you look at the screening, because screening for a country like India, technology itself is not enough. You have mammograms for basically. So you have look at roughly mammogram. There are only 3,000 to 4,000 mammograms available in the country. It's not good enough. That is a first generation, second generation mammogram. You also have to look at the Indian population is completely different, because Indian women have to have a denser breast. So where the generation one or two doesn't work, it gives a pain. So you have other technology, interventions which you can also use. And then while you are driving education, you can also talk about the steps of self-examination, which remains very cost effective and also drives the attitude. So there is a lot of work that can be done to detect, or bringing people for screening, or motivating and encouraging people and removing fear for screening. I've seen practically in many of the advertisements, etc., and all those things where we talk about self-examination. Nobody tells a young girl, that 80% of the lumps, etc., and all those things they see that are benign. We have a largest network of gynecologists, but then we don't make it mandatory if any women actually above 40 years of age is visiting any gynecologist, for whatever purposes. Actually, the history of cancer is to be taken in that family if any women in that family suffered from breast cancer, so that we know that this is high risk. Because in the for 60% of the cancer that you can easily identify high risk population, and at least high risk can be screened so that you can reduce the incidences. So there are many initiatives which are being taken, right? So to detect it early, over a last 10 years, at least there is a 4% improvement in detecting cancer early, right? Otherwise, it largely remains a disease where the incidence happens and then it is detected for some other purposes. The patient has gone to any hospital and got detected. Then when you do these things, and when you actually put these things together, then comes the detection to a treatment stage, because there's a lot of delay also happens, which leads to the progression of the disease to the next level when you've detected and you've not been able to provide treatment. Because treatment is pretty complex and you require many stakeholders who are coming together to detect to treat it. It's not a disease which can be treated by only one doctor. It requires a lot of efforts by different stakeholders. You require a pathologist also, you require a radiologist also, you require a nuclear medicine expert also. You will require, the entire family. Then you require support also while, you treat. And then, during the treatment and post treatment, because treatment itself is going to be pretty long. It's not a event based disease. It's a
Yeah.
disease it's a process based disease that happens, and it is to be taken care of to be taken care in that fashion. So the disjointed care should not exist in this, whether it is amongst doctors, whether it is amongst various specialties. And then you require a whole system, right, where the doctors are speaking to each other, because then only you're going to bring about the outcomes that you desire, right? So that happens. And so this is at a detection level or at a treatment level only, where I have not spoken about the kind of technologies that you have available, kind of therapies that you have available,
Yeah.
right? There are newer therapies that you have available. So that those are treatment technologies and detection technologies. In detection also, you have many. It's not that there is only invasive interventions that you require if it is a solid organ, or you have circulating plasma cells, etc., and all those things. There are a lot of tests which have come driven by blood and all those things which you can actually do, and also detect it before it happens actually. So those
Yeah.
are being, there are many of those are being actually into very early stages, and then many of them have been commercialized also. So there are many labs which are available which are doing it. So there are challenges around that also, but then it's largely there.
Yeah. Yeah.
So that is at that level. And when you talk about the post treatment monitoring, which is the most important aspect to prevent secondary cancers or relapses basically, and that requires a rigorous follow up. Those requires a support group, right? And then every doctor for that matter, and every institution for that matter, does those toxicity surveys, quality of life surveys, where the rigorous follow up happens. Unfortunately, I must say that, and I must admit it rather, that post treatment, rehabilitating back the patient into society, there's a lot of work needs to be done, because that's an area which is still neglected. And if you look at the compliance, because of the distribution of hospitals into largely urban areas where patients have to travel, so a lot of people actually fall off the grid when it comes to follow up and all those things. That's a pretty challenging area, because if you look at the rehabilitation efforts are not there, you look at palliation, it's still not there, and if it is there, it's there in a very sketchily available, which are individual efforts of organizations which are making it short. So that also impacts a lot. And then there's side effect management, because it's a disease where you've treated and there are side effects which are to be managed, which have consequences, which have a lot of follow-ups, and those are not covered in insurance. So I'm not touching the economic aspect of the follow-up, because that will have a large, because cancer is a disease which doesn't happen today. It remains there. It psychologically it remains there even if the patient is remission free, for a long period of time, or so the constant follow-up is required for that. And then you follow up through various So you got a PAT available for that, you got a blood, samples available for that, right? The once you've diseased. So, so that remains. So there are a lot of work which needs to be done around that.
Yeah.
So I
I'll
limit
come.
myself.
Yeah, I'll come back to you, Varun, for the second round, and I would request the speakers to have the responses a little crisp, so that we can come back for one more round. Dr. Manjiri, this question comes to you. What are the latest innovations in genomics in early detection and therapy selection, and then precision intervention?
Sure. Sure. Yeah. So, yeah, I guess, very frankly, genomics has been really making great advancements in the recent years. And it's really leading to a lot of great help for cancer patients, particularly in early detection, in therapy selection, as well as in precision intervention. For example, in case of early detection, earlier, remember, we used to look at X-rays or PET CTs, etc., mammography to really detect cancers. But nowadays, patient has to go to a hospital and do all of the scans, and that also leads to exposure to radiation. So nowadays, instead you have liquid biopsies, which is just take sampling your blood, and so patient can just in a outpatient in the this thing in any lab, you can give the blood, and it's a completely non-invasive method which analyzes the circulating tumor DNA. So tumor cells secrete DNA, and that is detected in the liquid biopsies, which can tell the analyzing person, the researcher, whether compared to a normal person, does this person has any additional tumor DNA circulating, may be the cause of the actually cancer. So that is really the biggest advantage genomics has in specifically in early detection. So liquid biopsies can, you can have circulating tumor DNA, circulating cells, and so on. Also, in specifically in genomics, when it comes to therapy selection, also there are really creative ways like single cell sequencing. Now, tumors, as we all know, the tumors can be heterogeneous. So some cells are at one stage of the disease, another cells are at a different, slightly advanced. They may have different biomarkers, and so single cell sequencing, which is a new technique, it really this technology, genomics based technology, really allows you to look at the various genomic profiles in a particular tumor, the individual based on individual cells, which provides great details into cellular heterogeneity in a particular tumor, and can lead to help in deciding the kind of treatment that the patient should have. Then there are CRISPR based technologies. CRISPRs are essentially you are cutting the genes and joining them or modifying them to really because cancer can have certain genes mutated, and so, can we use CRISPRs, which are essentially scissors, to really cut the wrong part of the DNA, which is mutated, and correct it? So, genome editing, enabling precise modification. These are all CRISPR-based technologies. Are another big advantage in therapy selection. Once again, and there is pharmacogenomics. There is epigenomics. So, pharmacogenomics is like individual genetic makeup is how does that influence the response to drugs, because if two people of the same age has the same disease, they may respond to the treatment differently. And so why is that happening? Because of the underlying genomics of the patients are different. So how does individual genetic makeup influences the response to the drugs? There is a whole field called pharmacogenomics, and by integrating this genomic information into drug development or in drug selection, in treatment decisions, pharmacogenomics has really enabled personalized medicine to a great extent in today day to day cancer treatment. And of course, genomics has earlier we used to sequence the entire genes. Nowadays, you can do long, short sequences, but short read sequences, and these are more accurate. These are more quick and can really give you reliable data where you have to sequence where you expect mutations. You can just sequence over there, and there is epigenomics also, which is the genes are there and they can be methylated. That is that there are certain modifications done on the DNA itself. So earlier we used to DNA leads to RNA and RNA leads to protein. So we used to look at those two. But there later nowadays there is enough and more information that even at genetic level, at the DNA level, you can have this methylation patterns difference, and that analysis of epigenetic information is extremely useful in many cancers in and also in other diseases such as neurodegenerative diseases, cardiovascular diseases, which also leads to targeted drug development. So, in general, what I am trying to explain to you is it's not just genomics. Of course, genomics is great, but transcriptomics, proteomics, metabolomics, that is what kind of metabolic derivatives we have, and based on that, how does our body function? So, all these are really these omics specialities are really collectively contributing to advancement of precision medicine, not just in detection, but in therapy selection, in precision medicine, personalized medicine, and help us to lead to tailored approaches which can really help in getting better clinical outcomes.
Thank you, Dr. Manjiri, for throwing light on the latest technologies which are promising. Now I come to Dr. Pallavi. You are heading this, leading this cancer hospital. At the same time, your specialization is gynecology. Uh, what are the kind of cancer related to gynec area that is basically prevalent, and what are the challenges you see? At the same time, what are the better treatment opportunities and cases in these areas? And you can also, since you are connecting with us from the state of Jharkhand, you can give the perspective of that particular state as well.
Thank you, Sudhirji, and thank you, my co-speakers. We had an awesome session now, and regarding the updates, I would like to highlight the first point is that as Jharkhand as a state, we are the 13th state, 13th in rank if we consider oncology and cancer treatment in Jharkhand. We are leading in the 13th rank. So here, Jharkhand being a very wealthy state, but still, as when we come for medical part of the thing, we see the cancer is prevailing a lot over here. Like if we talk about my hospital, this hospital came up in 2001 when we didn't have any cancer hospital around, and that time the problems we were facing were quite different with the problems we are facing today. If we talk up today, you must be heard about Kenny. It's a local thing we have over here. The females, they have this perspective that if you have Kenny, you have your working capacity increases, because the main work here is working in the field. For the rickshaw pullers also, it's a very good, they consider it a very good appetizer. They don't feel hungry after eating that. That is a very dry form of tobacco which they keep it in their cheek, and which is one of the leading causes of oral cancer which we see in Ranchi. Second, we go for cervical cancer. These two cancer in Ranchi, in Jharkhand as whole, are very much dominating. Cervical cancer, one of the reasons here are the girls here, the ladies here, they are mainly from the rural area. So they are quite less exposed to the urban population, because of which they don't even come with the disease to us. When they come, when they present, they have a huge mass in the cervical area, very friable. You cannot even touch it on OPD. When they come in the OPD, you see the mass and you're so worried. You don't even feel like taking a biopsy then, because you don't know how much the patient is going to bleed. When the patient comes with a history of bleeding, that is maybe 2 months, 3 months, 4 months after menopause. And one of the main factor here is they go for jari booty and all the village things they go for there, and that delays the treatment more. When the patient presents to you, the patient is already so in a so bad state, you don't know you need to manage the anemia at that time, or you need to treat the cancer at that time. You're very sleepless about that treatment part of the thing if you want to go. When the patient comes, if at all you have diagnosed the patient in an earlier stage, maybe second or third, and you can treat the patient, still the counseling part. If they are uneducated, they are not ready to go for treatment, because they feel, in Ranchi, they have that, madam, churi lagega to cancer badh jayega. They have that thinking over here. So they don't want to go for any treatment at all, because you need it's a blessing of the government here. We have Ayushman in Jharkhand. It is quite prevailing in Jharkhand. And in my hospital, maximum 95% patients are of Ayushman, of BPL. So we have that category of patient, but the government is so supportive. They are ready to do the treatment. But we can only proceed with the treatment if we have the positive biopsy reports. But the patient is not even ready to go for the biopsy reports, because they have this in their mind that if they go for any test, the cancer will proliferate more. Second thing is, if you counsel them somehow for the treatment, when they come for the treatment, they ask, the first question is, Madam, kitna time lagega? In that way also the counseling is so difficult, because if you go for radiotherapy, like for cervical cancer, if you have to go for neoadjuvant chemotherapy, then at all, if the patient is applicable, can go for OT, we go for OT. Otherwise we shift direct for radiotherapy. They are not ready to pay 5 weeks here. They can't stay, because they are, maximum of them are daily wage workers, maximum of them. So they earn daily, they work daily, and then only they have money to pay. But uh, it is quite difficult here in Ranchi especially in Jharkhand. We are coming up, my hospital being the only hospital for the last 10, 15 years, we are coming up with 3, 4 more hospitals in Ranchi in oncology. Still convincing the patients for treatment here is very, very difficult, very difficult. And both of these cancer are the presentation is very late. Though we are going for awareness camp, we are going for different modalities like Nukkad Natak and etc. They going for that, but it is very difficult. But still, like before, we are going used to go for screening camps. We used to get only 4, 5, 7 patients who were ready to come and get themselves screened. That has quite much increased. In the camps, we get around 100 to 200 patients for counseling. You can counsel them, you can tell them to come to the hospital, but the presentation is really very poor. Before also in Jharkhand, we had the age limit. Patients usually presented after 40 years, especially cervical cancer or breast cancer. Now we have as early as 14 and 15 years girls presenting here in RJSP, and we have operated them. We have got their radiations done. So the age bar is quite not reliable in Ranchi if we go for that. Even if a patient presents with a small mobile lump at the age of 15, 16, we cannot ignore it by saying that it's a fibroadenoma. We do pursue for FNSE and mammography, and unfortunately, 5 to 10% patients turn up to be malignant at the age of as early as 20 to 23 also. So, saying this, that it's very easy to diagnose, early detection is very easy. Frankly, from Jharkhand, it's very difficult, because patients are presenting very, very late. But now, because since we have also passed cervical cancer vaccine for government availability, I don't know when it will be available. But in Ranchi, people are that much aware that they come up with to the hospital, and they have this in mind that, ma'am, my family has been diagnosed with a cancer. I want to go with the cervical cancer vaccine. Or even people who are having breast cancer, young girls are coming with their mothers, with their grandmothers, and they have this history that we had a breast cancer history in the home, and we want ourselves to get mammography. So that we are having entirely two different groups of people who are presenting to us. One is completely aware, the other group is neither they are aware of the consequences, or no, they don't want to come up with it. Because one of the major issues in Jharkhand is the financial part. Even if through Ayushman or BPL, you counsel them for treatment, that the treatment will not be taking any money, but they have to leave the daily wage work for that. So that is a very big challenge for them. So
Yeah. Thank you, Dr. Pallavi. That seems to be quite a task for where the government's roles also come in to build awareness and at the same time enhance the education. Only then the late presentation of the patient might come down. This is something where we all need to work together. As Varun has rightly pointed out, the awareness has to go in even to the talukas and jillas. Now
very
I come to yeah. Saurabh, you have been handling operations in hospital for like more than 2 decades. So how do you see what is the kind of counseling and awareness the hospital provides at the same time? Does that awareness and education goes to the other family members as well? And what are the cases you see in terms of late detection, early detection, and the kind of therapy that is selected for that particular cancer? Over to you.
Sudhir, first of all, thank you for inviting me, and I am actually privileged to speak among such knowledgeable panel. Uh, Also, I think it's a matter of privilege that we are talking about cancer because for ages, cancer has been taboo. People don't want to talk about it, and that is also one of the reason why in India cancer is detected very late. So almost 70% of the cancers are actually detected at the advanced stage, and the mortality, ratios are almost double than anywhere in the West. So, for example, 70% of the mortality in cancer is attributable to low and middle income countries. Um, Also, as we know that things are changing, and people are now talking about more and more detection. When it comes to hospitals, I think what we are trying to do is first of all, and I'll have to segregate it because the manner in which hospitals actually try to detect and counsel is very different from the general practitioners and the rest of the masses. We must understand that the corporate hospitals or the hospitals which are equipped to handle cancer are very few and not even represent 10% of the total space. And in India, we have, like as less as one oncologist per 10 lakh population as compared to like 161 in the US and other places. So the resources are scarce. Again, almost 80% of the facilities are located near the metros, and rural India does not have neither the infrastructure nor the expertise. So what we actually face is when patient actually lands up in one of our hospitals, we see, as I said, cancer at very advanced stages, and I think Dr. Pallavi was actually attributing to jadi booty and other stuff. So we actually see a lot of experiments already tried on the patients, and which has in sometimes has worsened the case. So what we have done is, in my previous organization, Miranta, we actually had a cancer screening vehicle which used to go, from villages to villages, and we adopted villages to actually tell them about, how to self-examine, especially in terms of, breast cancer, and what is the importance of hygiene, what they should do. The vehicle was equipped with mobile mammography and some basic laboratory investigation, and the whole villages were adopted. Also, what majority of the hospital groups, including ours, is doing is we are educating the RMPs and the GPs, because in India there is a phenomenon where you don't refer. So a patient is landing up in a GP or a RMP, they will try to self treat, and sometimes even things which are not cancer actually end up being cancer, because it's a nodule which is a non-cancerous, not need not be operated, but there is a local surgeon who operates. We have seen cases like this. So we actually encourage them to first of all refer to a specialized center. Then they should talk about latest modalities for detection and then treatment, because the treatment is changing. I was reading somewhere 4 days back, India has come up with CAR-T, which is the Indianized version, and it is almost 10% of what happens in the West and other places. So we should know, we should educate these people. Also, as I said, it's a taboo. So we have counselors in the hospitals, and this is what majority of the hospitals do. We counsel the patient, and we tell that majority of the cases are 100% curable if it is individualized treatment, and nowadays you have gene therapies and other modalities available. Also, it is an end-to-end approach, because what we do is we try to involve patients who have fully recovered as case examples, and social support groups are there in hospitals who reach out to patients, who guide them, because there are a lot of side effects with the treatment, how it will go, and how their journey has been. So even after the treatment, it's detected first of all, then treatment is given. Then what are the like yearly examinations, and how to cope up with the social stigma and stress. that is also being taken care of. So it is basically a 360-degree approach. Majority of the hospitals do that, but again, this is very limited. It needs to be scaled up because the corporate hospitals only represent 10% of the healthcare delivery. Again, it goes back to rural India where they don't know what to do. But again, hospitals are at least doing trying to reach out. And now with I think Varun has already spoken. There are a lot of modalities available. One is I was mentioned Niramai in Bangalore, where you can actually do heat signature of the breast without even removing clothes, which is a big taboo in Haryana, Punjab, and other places. You
Yeah.
can get as accurate result as mammography. You need not press the breast because breast density is higher in India. So such modalities, and even the cost is much less. Even the capex cost and the ticket size for per patient. So I think these modalities are welcome. Some of our hospitals have actually tried putting these modalities and have given leverage to these startups because the way the detection and diagnosis plus the treatment is happening with oncology, it is changing as we speak. Newer modalities are coming every day, and we need to imbibe them. And technology is here actually not to increase the cost, but actually to increase the reach of existing resources and to make it accessible to the population.
Thank you, Saurabh, for bringing in that picture here. Varun, I come to you now. Basically, there are many patients coming at the same time. Usually, the cancer is one of the main reasons is said to be is like it is in the genes. And after a patient comes in, is what is the kind of behavior or trend you see in the other family members so that they also get screened and they also adapt certain things where they make changes in their lifestyle or screening, and at the same time certain section of people, maybe people who are well off, would prefer regular screening. But what about the people who are in the rural India and those who are not economically well? What is the trend you see?
So, so, so these, thanks for asking. But before that, I must thank Dr. Pallavi Pandey and Dr. Manjiri, because see, they have actually in one session they have put the disconnect, and the gap between what is available and what can be done and what is actually the reality is. So I
Yes.
must thank them, and I must share it with Dr. Pallavi that across the country, if you go away from the urban areas, the situation remains more or less the same. It's
True.
actually quite ironical, that we
True.
have a lot of treatment available and we have a lot of newer therapies, what Dr. Manjiri was talking about, and yet we have that disconnect. And that comes because there are many things which Saurabh has spoken about: taboo, late detection, and then the jadi booties, alternative systems, and all that. So I must thank you, thank three of you for
Thank
that.
you.
And now I'm coming to Gautam's question very briefly. See, so the issue is that the people who have the the money and the resources to seek treatment in a hospitals where you have all technologies available, their reaction is completely different, right? When they come to it, they are definitely in trauma. They are definitely want to know more about it because they're educated about it. They know that these therapies are available. So there is a mechanism of counseling them, taking the entire history, looking at their lifestyle. So you have a genetic counselors available in hospitals who will actually, after every session, they will talk about that the family tree. They'll look at the history, and then they will try and identify if there is a high risk group or not, and then the hospital speak about it that this family has a high risk group, so bring them for investigation or preventively get these things done. So that is largely true for the people who are in urban spaces, because their attitude towards health and their information and awareness is pretty good, right? So that is easily doable in urban spaces. But the moment you come away from urban spaces, so I often say that you go away 50 kilometers from any city, whether it is Delhi, whether it is Bangalore, or whether it is Chennai or Hyderabad for that matter, or Calcutta, the situation changes. So when they come to a hospital, counseling them even for a mammogram, or counseling them even for a simple OPD, or counseling them even for a proper examination itself becomes a different difficult to do that. So there is a lot of actually support required, and most hospitals are not equipped with that support, because you require counselors, and those counselors, you require nurses. So you don't have a nurse. Actually, it takes a lot of time to prepare a skill of a breast nurse who can actually do the examination and can reduce the work of a doctor, whether it is a surgeon, or whether it is a medical oncologist, or whether it's a radiation oncologist for that matter, and can prepare that these are the tests which are required, right? So there's a lot of work that is required at that level. And second thing is, once you have detected, convincing them for a treatment itself takes a lot of time. It's not easy. I can tell you that I can understand the pain Dr. Pallavi has shared, that it is very difficult despite having Ayushman Bharat. And I must credit the government of India for this, because Ayushman Bharat at least has brought more people in actually seeking treatment for that.
Yeah.
It's a different matter. See, what's challenging after that is the if you have convinced them for treatment, you have counseled them, while you are counseling them, you also have to factor in their social environment, which place they are coming in. What are the taboos in that places? Whether it's a closed society or it's an open society, right? Whether there is some young person is there in the family or not. See, there will be the entire family gets disturbed. I told you initially, the moment somebody is detected, then the existential crisis comes in. If it is a young patient, right, or if it is a patient who is 45-year-old and only breadwinner, it becomes very difficult for that family to come continuously and seek treatment. So most hospitals now have started the follow-up telecommunication, right? The video calls, the WhatsApp calls. So that is for follow-up. They also try and see. So I can give you an example like head and neck. So there is an association of dentists. So what we do is, in rural areas, there are a lot of dentists available. People do go to them because their services are available, and you have to take care of head and neck. There are a lot of you have female doctors who are, in fact, even if they are physician, you actually contact them and you ask the patient to go there for follow up, and you, in that process, you develop attitude of those ASHA workers or those doctors at a taluka, village, panchayat level. And if this I worked on a rural strategy a lot. Even if the sarpanch happens to be a female, it's very easy to actually penetrate that area and ask them to go and set up an information system. And in that information system, the follow-up patient at least can speak, can do a video call, because now you have internet available, so that you can reduce their cost and continue to motivate them to come for 6 months or 1 year after. And then
Yes.
you have, like Dr. Manjiri said, that you have blood investigations available. Through them also you can look at the remissions and all those things. So this is a Herculean effort the moment you go out of urban areas, because of deficiency of infrastructure, deficiency of actors, right? And then you have the network not being available there, and then you have social taboos, then you have a family taboos. So it's very difficult for the family to deal with them, and you have to counsel the attendant also, who is the immediate attendant. So you have to train them on a lot of procedures, how to drape, what to do when he's feeling that, what is to be done in pain, what is to be done. So there are a lot of things which are to be done. So that's my take.
Yeah, thank you, Varun. This kind of building awareness is very, very important, and we need to bring in the government machinery, and there is a joint collaboration needed between the private sector and the government sector. I know some of the speakers have to catch the flight. I'll wind up this session in another two minutes exactly. Dr. Pallavi, there is a question for you
Yeah.
from the audience. Are there any post-treatment side effects or symptoms, and when should I seek medical attention for them? Maybe after some treatment is taken.
Treatment, it completely depends on which cancer you are having, and you have been treated for which cancer. Because if it's a breast, we take a recheckup after 3 months, and then 1 year, and then maybe it's negative, then 3 years, then 5 years. So it completely depends on the treatment you have taken, the modality of treatment you have used. It's a surgery, it's a chemotherapy, it's a radiotherapy. it depends on all the cancer you have, the patient has undergone, like for breast, once we have treated the breast, we have gone radiotherapy is fine, and the patient has been sent back with good results. We keep the patient on letros for almost lifelong. So it depends on the first year, we call them in a 1 year interval. If everything is fine, we call them in a 3 year interval, to get the basic tests done, to get the physical examinations done. So it completely depends on the cancer the patient has gone through.
Yeah, thank you, Dr. Pallavi. As you have also touched upon the breast cancer part, Dr. Manjiri, I come to you. What is the best opportunity you see in the breast cancer diagnosis? A quick response. Yeah, you're on mute, doctor. Can you unmute, please?
I think the biggest opportunity we have, as I think Varun alluded, Pallavi alluded, as is the early detection. That is the most important opportunity, challenge as well as opportunity, because it's a challenge, it's an opportunity to come up with more sensitive techniques, more easy techniques, so women will not shy away, so that is really the topmost priority that we have. And I mean, apart from that, we can of course certainly do far better in understanding the tumor biology, so everybody gets a tailored treatment. Everybody doesn't get one size fits all kind of treatment. So understanding the tumor and then treating the patient, what we do today is okay, patient cancer hai, first remove the tumor and then give chemo. But is that chemo going to benefit the patient, which chemo to take? So there you can do all this analysis if you have the tumor tissue, and the devil is in details, as we all know. So doing that kind of analysis is really the most important challenge as well as opportunity, in my opinion.
Thank you, Dr. Manjari. A quick response from you, Saurabh. What is your take on people who are afraid of the cancer coming back after the treatment? What is the monitoring system? Quick response from your end.
So the monitoring system can actually be as simple as yearly checkups, and generally we attach the patients to a social group. So there is a peer network which actually pushes them to get the examination done, and are some basic tests which can be done. Some cancers do have these tendencies to get back, and nowadays we are talking about the digital mediums and AI based chatbots and all. So we have incorporated some of those to actually remind the patient automatically when the time of the checkups and related things come. So AI has a big role to place into this, and majority of the when we map a patient life cycle in oncology, we have these milestones also, which is post treatment. So that's my take.
Thank you, everyone, for that wonderful insights and your time. I really appreciate, and as a token of appreciation, we give this participation certificate to our esteemed guests. So first, we would like to thank Dr. Pallavi Pandey, Executive
Thank you.
Director, RJSP Hospital, Ranchi, Jharkhand, who is also a
Screenshot.
gynecologic specialist, for the kind of heartfelt gratitude for your insights and expertise. Next,
Thank you.
thank you, Dr. Pallavi, and we move on to Dr. Manjiri Bakre for taking out time and the insights you have shared. And I'm sure we will be looking forward to more collaborations and the kind of PPP that can happen between the government and organization like OncoStem. Thank you, Dr. Manjiri.
Thank
And
you.
coming to next, Varun, thank you so much for bringing in that holistic approach towards the monitoring, at the same time creating awareness and all. Thank you. Next, we come to our passionate health professional, Saurabh Gupta, for bringing in that insights that happen in the hospital and overall monitoring system.
Thank you so much.
Thank you everyone for joining us. We'll get back to you soon. And just wanted to inform you all, we with the Ministry of Development of Northeastern Region, with all the 8 Northeastern states, we are coming up with yet another edition second IndiGlobal Cancer Care Symposium that would focus on Northeast states, where the participation, the audience would be majorly from the institution, educational institution, and all the health departments. They want it is to create a larger awareness in regards to early detection, treatment, and as Saurabh mentioned, the taboo to deal with that kind of challenges. So we look forward to have you there as well. We'll get back to you soon on that. Thank you very much for joining us.
Thanks everyone.
Thank you. Thank you so much, everyone.
Thank you, everyone. Thank you.
Thank you. Bye bye.
Bye bye. Bye.